Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Okay. So once again, I welcome everybody in the class, and we are about to start with the fibroid case presentation. Over to you, Nikhil. Please start.
So Ms. X, 48 years old, wife of Mr. Y, resident of Karol Bagh, New Delhi, homemaker, studied up to class 12, belonging to low socioeconomic status.
Okay. So I want everybody to please mind these two important things over here, which is the age of the patient, okay, and also the economic, low socioeconomic status, okay. Mostly these two important histories. If at all you are speaking about a case of menorrhagia, AUB, fibroid, whatever, that will come later. Yeah, please continue.
Presented with the chief complaints of heavy menstrual bleeding since last 6 months, pain abdomen since 6 months, and distension of abdomen since 1 month.
Okay, so just by this history, okay, just by this history alone, that she's having heavy menstrual bleeding, she's having pain abdomen, she's having distension abdomen, she's having three main presenting symptoms. Something is coming into your mind, right? So can you just tell me quickly what DD is coming into your mind so that we can accordingly ask her the history?
It's a case of uterine bleeding, ma'am. So the differentials are fibroid uterus, adenomyosis, endometriosis, adnexal mass.
Yes, absolutely. And why we are limiting ourselves to these different pathologies is because we also have distension of abdomen. Distension of abdomen is a very characteristic symptom of what?
Adnexal mass.
Yeah, mostly ovarian tumor, you can say any ovarian tumor, okay, be it malignant, be it benign,
Yeah.
usually presents with distension of abdomen, bloating, distension. That's how the patient is going to come to you. So very characteristic symptom, specifically actually of that of ovarian carcinoma, but ovarian tumor will also suffer, okay? So remember that our DDs are hovering around what? All those things which will cause all these three things together. That is, he just said that it could be just fibroid uterus because that will cause this thing, distension, heavy menstrual bleeding. What about pain? Would fibroid uterus cause pain? Usually, does it cause pain?
Yes, ma'am. In case of degeneration of fibroid, it may lead to pain, or sometimes there is torsion of subserosal fibroid may
Okay,
also
very
lead to
good.
pain,
That will
abdominal.
also lead to, but that's acute pain, okay? But since she's having pain
Yeah,
since 6 months, anything else that is coming into your mind? That fibroid along with what will cause pain?
ma'am, fibroid is also associated with endometriosis that also might lead to pain.
Mostly adenomyosis. We call it adenomyoma or fibroadenoma of the uterus. Okay, so that is a very,
Fibroadenoma.
yeah, it's not a very rare condition. Let me tell you that it's pretty common. Okay, mostly it is seen fibroid is associated with adenomyosis or endometriosis most of the time. Okay, most of the time. Fibroid with adenomyoma is not a very rare occasion, rare entity. So yes, you will have these other DDs which are coming into your mind when you've just questioned the patient. She's just given you presenting complaints, right? Now your history is going to go, you are going to describe this patient remembering that these were the DDs in my mind. So you had fibroid uterus, adenomyosis, you had adnexal mass, and maybe an endometrioma, which she'll not be able to categorically tell you, which will cause both distension, bleeding, heavy bleeding, and pain. Okay, go on.
Patient was apparently all right 6 months back, and she presented with complaints of heavy menstrual bleeding since last 6 months, associated with pain during menstruation and passage of clots. Cycles were regular, lasting for 10 to 12 days, changing 8 to 10 pads a day with passage of clots, and with history of waking up at night to change pads.
So she's having this problem since 6 months now, and earlier her cycles seem to be pretty okay, but now her cycles have become heavier. Have they also become irregular, or they are regular? They're regular.
Regular, ma'am. They are
They're
regular.
regular. And very categorically, earlier she was using how many pads?
Ma'am, she used 3 pads.
She was using 3 to 4 pads, right?
Yeah, ma'am.
All right. So, can we call this menorrhagia? If at all, then what exactly is the definition of menorrhagia? What should be it?
Ma'am, menorrhagia, it's a subject. If the patient gives history that there is increase in amount menstrual bleeding, then it's called menorrhagia. It's a subjective definition, ma'am.
Yes, any such bleeding that will lead to a compromise in her physical, mental, social, especially social lifestyle. This is according to RCOG, beta. Okay, we have a lot of
Yes,
definitions
ma'am.
that increase in the cycle length. We have increase in the cycle amount. Increase in length is okay. That's also understandable. So earlier she was having a period of, let's say, maybe 6 days or so, and now it is 12 days. So obviously that will be called as menorrhagia. But it's very difficult to describe that earlier she was having only 50 ml bleeding and now she has 80 ml bleeding, or she was having 30 ml bleeding and now she's having 120 ml bleeding. Most of the patients will not be able to give you a proper history, and most of them will not be able to give you. See, some patients change heavily soaked pads. Some patients change a light pad also. So if somebody is changing, let's say 7 to 8 pads a day, it's not necessarily that all the pads were soaked. Maybe she's just a very hygienic patient and she'll just keep. So these are not very leading definitions, but a definition which says that earlier I used to not have even one day off at my work, and now I have to take three days off every month for work. I'm feeling tired most of the time. I'm feeling weak most of the time. I'm irritated. So this is subjective, all right? This is subjective. It's a bleeding that is very categorically telling her compromise of her lifestyle, compromise of her, her emotional, physical, and mental lifestyle, I would say, because of the increase of bleeding. So yes, definitely this will be the definition of menorrhagia. And if you have guys of in my class, if you have a definition from any other guidelines, any other school of thought, you're most free to share with me. Whatever is given in your standard textbook is also equally good. All right, I am sharing something which is according to one of the guidelines. You can share ACOG guidelines, you can share FIGO. FIGO has a different definition. Okay, FIGO watches about the days of cycle. They say a usual cycle lasts for about 21 to 35 days. So any cycle which is lasting for more than that, or a cycle which is coming too regularly, too irregularly, it's coming before 21 days or it's coming later than 45 days, that's an erratic cycle. But menorrhagia, what do they mean by menorrhagia, is usually depending on the amount of pads they are changing. This is according to FIGO. Joyce has written heavy bleeding during menses more than 80 ml, I should say, in a regular cycle. Yeah, that's by the definition. But according to RCOG, they say it's any such heavy bleeding that is causing a compromise in the lifestyle of the patient, emotionally, socially, physically, that is called menorrhagia. All right. Now tell me more.
She also complained of pain during menstruation starting from day one of the cycle and lasting for 2 days and relieved with analgesics. In lower abdomen, pain was insidious in onset, gradually progressive, dragging type, present throughout the day, radiating to back. There was no aggravating factor. There is history of loss of appetite since 4 months. 2 weeks back, she consulted a local doctor for heavy menstrual bleeding and was told to have low hemoglobin and was prescribed medicine to stop bleeding, probably tranexamic acid, from which she didn't get any symptomatic relief.
All right. So we always give this as the first thing. Usually, any patient who comes to us with a complaint of bleeding, heavy bleeding along with pain. So, what is your first choice to give to a patient who's coming with heavy bleeding with pain? What do you give?
Ma'am, tranexamic acid with mefenamic acid,
Usually, we give
hexadecimer
mefenamic acid
in brand name.
suffices both ways, beta. Okay, mefenamic acid
Yeah,
is
ma'am.
recommended, in fact, by the college. They say that it is helpful in both reducing the amount of bleeding and the amount of pain both. Tranexamic acid alone, we give to a patient who's coming only with heavy menstrual bleeding, no other symptom. Okay, in our case, she had sufficient
Okay.
pain as well. So tranexamic acid is for bleeding alone, and mefenamic for bleeding and pain both mixed. Okay, now give me the mechanism of action of both these drugs.
Ma'am, tranexamic acid is the plasminogen activator inhibitor, so
Inhibitor.
it helps
Yes,
to
you remember this, guys?
reduce the
Yeah.
blood loss.
You call it PAI, plasminogen activator inhibitor. So that is the mechanism of action of tranexamic acid. And what dose do you give it in?
500 mg, ma'am, TDS for 3 days.
Yes,
For
TDS.
first 3 days of the cycle.
Yes. And that should be sufficient to at least reduce the bleeding. And it's a very effective method, let me tell you that. Okay, do not underestimate tranexamic acid. It's pretty much there in almost all guidelines, and it's one of the first lines to give to a patient with heavy menstrual bleeding. All right. And what about mefenamic acid?
It's an NSAID, ma'am, so it helps to reduce the pain and also to
Yeah.
reduce the blood loss.
COX inhibitor decreases the prostaglandin release, right? So it is the most
Yeah,
important
ma'am.
factor to reduce, because we know that uterine activity, uterine contraction during the menses also is because of mostly prostaglandins, right? And it reduces the amount of prostaglandin, so the pain is inhibited. Absolutely. And it's very, very effective again. Go. Now comes the most important point, which is the negative history, which I have all my eyes on. Yeah, please go ahead.
There is no history of heaviness in lower abdomen, increased frequency of micturition, burning micturition, difficulty in passage of stools, intermenstrual bleeding, mass coming out of vagina, discharge per vaginum, weight loss, fever, no history of blood transfusion, and no history of easy fatigability, dizziness, swelling of lower limbs.
Okay. So like I've told you before, and any examiner will stop you here to ask you why the negative history. It is the most important thing. See, again, guys, at your point in time, certain histories, they become, I'm trying to just emphasizing upon the things that are even important at your level, at the level of postgraduates. In these first 2-3 cases, I'll take a little elaborate, and then we'll only discuss the important points, because sometimes in exam, by the time your roll number comes, if the examiners are so fatigued and so tired that you don't want to hear your, each and every point. They want to just know just tell me the salient points of your history. And there at that time, you should know what to pick from your history. Okay, do not fumble. Be confident in telling them. And since you are being confident in telling them, pick the right points. This is what I'm trying to tell you. If you are giving a negative history, be very sure what you have to speak with respect to your case. Okay. So, for example, there is no history of heaviness in lower abdomen. Okay. So, why did we ask that?
Many fibroid uterus adenomyosis or adnexal mass is associated with heaviness in lower abdomen.
Okay.
Generally, so we ask if there is any, she feels heaviness in the lower abdomen.
Okay. Fine. Then next.
Ma'am, increased frequency of micturition, any abdominal mass presses on the urinary bladder, so it may lead to pressure symptoms like increased frequency of micturition or
Yes.
difficulty in passage of stools.
Yes. Correct.
And it may also lead to retention of urine, which
Retention.
later
Yes.
leads to UTI.
Yeah. So,
That's why burning micturition is there.
okay, had he said no pressure symptoms, I would have made him speak all these things. Okay, since he's already written it down, I'm rather happy that instead of asking, me asking the question, we already have now. Why is he speaking all these things? Because he's just trying to elaborate that whatever the mass inside it, if at all there is a mass inside, it's not causing any symptoms. We are presuming that she's having distension. We are presuming that she's having pain. We're presuming that she's having a bleeding PV, heavy bleeding PV, congested pelvic syndrome. We are expecting some mass to be there, most probably. Now, if there is a mass, if it's causing any problems to her or not. So there is no associated heaviness, increased micturition, burning micturition, or any difficulty in passing stools. No other pressure symptoms, right? Go on. Why the intermenstrual bleeding and why the mass coming out of vagina?
Intermenstrual bleeding is usually associated with polyps, so we have ruled out that, and mass coming out of vagina because sometimes there is fibroid polyp, so mass per vaginum history we have taken. Then discharge per vaginum, we have seen that if there is a
Yeah. PID? PID infection, anything. Are you speaking or your voice is gone? We can't hear you.
no internet is breaking in between. That's why
Yeah.
I think the voice is breaking.
Okay, all right. So, see, whenever you have a case of heavy menstrual bleeding or any abnormal uterine bleeding, intermenstrual bleeding becomes a very important point. You have to speak that, okay? So, if suppose an examiner asks you that why are you taking a history of intermenstrual bleeding, so just say she came to us with menorrhagia, and we need to know if she's also having periods of intermenstrual bleeding in between. Okay, so then he'll ask you why then, if suppose she had intermenstrual bleeding, then what will you suspect? The answer will be either a fibroid uterus or polyp uterus or some local lesion. Correct? Any local lesion can cause intermenstrual bleeding. There's no need to specify, because in your case, in our case, we do not have to be very specific about cervical ectropion or mass cervix, because if there is a mass cervix, it will not cause pain, distension, and all above, until unless, of course, there is meds, frank meds. Right. So weight loss fever, because we just wanted to mention that it is not a very, what do I say, malignant transformation of anything, right? So she'll have a history of chronic weight
Yes.
loss, or we spoke about decreased appetite as well, right? So in that case, we have to delineate this history as well. So no easy fatigability, no dizziness, no swelling of lower limbs.